The femur is the longest bone in the human body, and for most people, it is the strongest bone as well. The femur needs to be strong because it is surrounded by some of the largest and most powerful muscle masses in the body. When the femur is broken, these powerful muscles lose their support system and spasm in an attempt to hold the femur in place. These muscle spasms typically cause a tremendous amount of pain for the patient. The traction splint can help realign the femur back into its anatomical position and thereby reduce these painful spasms. An equally important function of the traction splint is that it can help to protect or restore the neurovascular function of the injured leg. Let's talk about when it is inappropriate to use a traction splint. The traction splint is contraindicated for the following conditions. If there is an immediate life threat, if the patient is unable to protect their airway, having difficulty breathing, or is hemorrhaging, the traction splint is inappropriate. If there is any other injury to the affected limb, including the knee, ankle, and foot. If the patient has an open or bilateral femur fractures. If there is any hip or pelvic instability, you cannot apply traction to an unstable base. Also, a pelvic or hip fracture is usually indicative of potentially life-threatening internal bleeding. If the patient has significant multi-system trauma, hemodynamically unstable patients would not benefit from the additional time on scene that is required to apply the traction splint. Due to these contraindications, the traction splint is not a piece of equipment that gets a lot of regular use in the field, which makes it that much more important to practice with. In this video, we will be demonstrating the correct application of a Hare traction splint. The first step is manual stabilization. This would be an appropriate job for an additional responder on the scene if available. For example, a fireman or police officer. If this resource is not available to you, one partner will prepare the splint and ankle hitch while the other holds manual stabilization until it is time to apply manual traction. Next, one partner will prepare the traction splint. Wrap a cravat around the area where the ischial strap is located. You will use this cravat to provide padding and extra support to the ischial strap. You want to wrap the cravat around what will be the medial side of the fractured extremity. This way, you will be able to tie the cravat on the more easily accessible lateral thigh. Measure the traction splint on the uninjured leg. Femur fractures typically cause deformities, such as a shortening and external rotation of the injured extremity, making it unsuitable to use for measurement. The traction splint should be measured beginning at the iliac crest, the most anterior portion of the pelvis, until the groove at the end of the traction splint lines up with the bottom of the patient's foot. The patient's foot should look like it would be able to fit into the traction splint as if it were a stirrup. After measuring, it is a good idea to prepare your straps and put them in the approximate locations where you will want them on the injured extremity. Pulse, motor, and sensory function must be assessed on both feet, then apply the ankle hitch. If there are only two providers, you will need to divide up the responsibilities. Be sure that both providers are aware of their roles, because once manual traction is applied, it needs to be maintained for the duration of the splint's application. As you prepare to take manual traction, the hand on the medial side of the injured extremity should be on top of the foot, while the other hand on the lateral side should be underneath the ankle. This ensures that manual traction is pulled in a way that closest resembles the natural anatomical position of the femur. After manual traction has been taken, line up the traction splint under the injured extremity and slide the splint straight upwards until the splint rests against the ischial tuberosity, also known as the butt bone. Helpful hint: drape the ischial strap and cravat tails over the uninjured extremity to avoid them getting lost. Next, take one of the cravat tails and wrap it over the injured thigh and under the splint. The ischial strap will be placed over the cravat. Both should be positioned as high up on the thigh as possible and at an angle that resembles a person's underwear line. Secure the ischial strap. Take the other cravat tail and place it over the ischial strap. The ischial strap should be between the two cravat tails, as if you were making a sandwich and the cravat tails were the bread. Secure the cravat by tying the two tails together around the outside pole of the traction splint. Lower the stand of the traction splint, secure the hook to the ankle hitch, and apply mechanical traction. Talk to your partner. They should feel the splint taking over a lot of the work, but they do not let go yet. Next, secure the injured limb to the splint, starting with the most distal strap and moving proximally. Remember, a strap should never be placed over the patient's knee or over the fracture site. The first strap should be placed on the patient's lower leg, just above the ankle hitch. The second strap should be placed below the patient's knee, and the third strap should be placed above the patient's knee. This brings us to our fourth strap. If you are able to secure the fourth strap without placing it over the brake, then do so. However, this will not be possible with most patients, so instead, secure the strap under the patient's thigh to help support the heaviest part of the leg. Recheck mechanical traction and tighten it further if needed. The EMT who is pulling manual traction should indicate when enough mechanical traction has been applied to equal his or her pull. Recheck that all of the straps are taut, or else the leg might dip when manual traction is released. Only now, after all of that, can manual traction be released. Finish by reassessing pulse, motor, and sensory function in both lower extremities.